Ladies and gentlemen, it really gives me a great pleasure to welcome Dr. Johnathan Schaffer to the stage, the Managing Director of the eCleveland Clinic in the United States, which connects people through My Consult and Doctor Connect and many other things that we'll hear about. Johnathan is an orthopaedic surgeon. He just does knees. You can see him during the break. Consultations are possible. He's also Program Director with the Advanced Operative Technology Group in the Orthopaedic Rheumatologic Research Centre. So please welcome our first international guest, Dr. Johnathan Schaffer.
Thank you, Julie, and it's certainly a pleasure to be here this morning. And thank you for the opportunity to talk to you about some of the programs that we have at Cleveland Clinic. I know one of my colleagues, Martin Harris, was here a few years ago, and we want to share with you some of the things that we've done to help connect all the stakeholders in the enterprise. And Sally, thanks for the kind invitation. So what we need to look at, and I can't help but think of, from the States, our perception of Australia and that famous road. But this is really a journey to eHealth and transforming healthcare. And as we've heard, having the right outcome, the right value, there's a whole string of things that need to happen along the way. But we have a problem. How many of you have an older sibling? Raise your hands. How many of you have a younger sibling? So sharing is not something that's ingrained in us at birth. And if you were the older sibling, as I was, we weren't always the best at sharing with our younger siblings, especially if they asked, and vice versa. So how do we overcome this? And it really depends, as Mukesh said, is how you're raised and how much trouble you'd get into and if you got caught. But in this day and age, we do need to share, because if we're going to share information, and as a surgeon, it's not just I go in there and do the total knee. I always tell my patients, you have a flat tire. You've got no cartilage left, and it's bone on bone. And I know I can replace the knee each and every time, and it'll come out doing just fine. But the problem is if you change the tire and the engine doesn't run after you change the tire, you have a problem. So the conversation is changing. As you see from this graph, if we have the ideal outcome, that is the best value. And that, as Mukesh mentioned, that's what we're after, is how can we get the best value in healthcare? But whose problem is it if you have non-compliance? Is it the patient? Is it the provider? Is it the institution? Is it the family? We all have a shared responsibility for this on how do we avoid noncompliance, and that will increase your cost. That will decrease the value. And certainly if you have to have a reoperation for whatever reason prematurely, looking from the surgeon's perspective, then that's the highest cost, the least amount of value. So we need to change the way we look at this. And I want to share with you a journey that we've been on at the Cleveland Clinic, really for the past 15 years, but with our EMR fully functional for the last 10. Because there's certain challenges we're all facing worldwide. You all know these very well. Everybody's getting older. Somebody in Australia is turning 50 every 7.5 seconds now. Finance, it does cost more. How much of GDP? What is the right number? How do we value good health, as Desmond Tutu mentioned? And the technology has certainly seen an explosion in the past few years. How many of you are walking around with a tablet of some sort and can't wait to get the new one when it comes out? Well, then there's another issue. We should be intolerant of the geographic barriers to care. They just shouldn't exist. So we've become agnostic to those geographic barriers, because then if you get rid of the geographic barriers, you can increase engagement. So if my post-op patient is 10 miles from my office, or 100 or 1,000 miles, it shouldn't matter. How do we keep them engaged, and how do we make sure they're doing what they're supposed to post-operatively? So we really want, from a surgeon's perspective, the optimal operation. And there's a little bit of a flaw in that as well, because we need to have the optimal environment, the optimal patient, the optimal surgeon. I always say that's the easy part to get, as you'd expect. And the optimal implant, if I'm doing a total knee or total hip, and obviously the optimal outcome. So really we need to change this around, because the operation shouldn't be first, it should be the optimal patient, patients first. So we alter it, and then whether you use the word optimal or right, it doesn't matter. It's how do we create the right or optimal outcome, which will give us the best value. And what drives those outcomes? We've determined it's experience. And that is become an expert in certain things, do it often, do it well, and know your data. So we publish our outcomes books every year from every single clinical department. And that way we know what the complications are. When I quote somebody the DVT, the deep vein thrombosis rate after total knee replacement, we know what the numbers are. We know what the infection rate is. And we also can tell them, if you do this, you have a better chance of success at the end. And same thing for our Heart and Vascular Institute, looking at aortic valve replacement, mitral valve repair, CABG, bypass graft, whatever it is, you need to know your data. And the only way you can know the data is to have a system that you can collect it. And it's not just collecting post-operatively, did the patient live after the operation, can they walk? There's a lot more data that needs to be looked at. And we really feel that we've got some, we call it the secret sauce, with the barbecue and making sure that you've got, the right combination so you have the optimal environment. We are a group practice, so all 2,800 of our physicians are full-time employed physicians at the Cleveland Clinic. We're all salaried, and a bit more about that in a minute. We no longer have the traditional department and division structure. It's all institute-based, so if you're in business, think product line. All the heart and vascular folks are together in one institute in their own building, so the vascular surgeons, the vascular medicine physicians, the cardiologists, the heart surgeons, all the imaging related to that, the chest surgeons, all together in one building within campus, their theaters, their rooms, the ICUs, the patient rooms, their offices, everything's all together. And then the EMR adoption has certainly given us the ability to really move this further ahead. We can then focus on efficiency, and we'll come back to that a bit more at the end of the talk, and publishing the outcomes every year becomes a key piece of this. And with these pieces, these 6 items, we can try and improve the value that we're providing for the patient. You'll see where the connections come in, because that becomes important. But our group practice model is really the basis for all this. So we have 1-year contracts, and every year you go through an annual professional review. You meet with your various center directors, your chairs, whoever your leadership is. And for me as a clinician and administrator, I've got both the IT side and the orthopedic side. And they go through all of the data. They know more about what you did than you can imagine. And they'll look at the complication rates. They'll look at your outcomes, patient satisfaction, number of cases you did, number of papers you presented. Every little detail is looked at, because now we can drive what we call our patients first decision making, and we can improve protocol adherence. So all of the joint replacement surgeons, there are over 30 of us, can follow same, if not identical protocols on how we do things. And that really can drive quality and value much, much further. Now, having the EMR since 2002 also gives us the ability to look at the data, make a change, reevaluate it, and more about that today and then in the panel this afternoon as well. Well, we didn't quite start the way that I've described. We started as a single building in 1921. That building still stands on campus. It's actually right there, if you see the arrow. And that has changed a bit, because now we've got main campus. We have our regional hospitals in northern Ohio, and our full-time staff populate main campus as well as the regional facilities. But then there's also community physicians who are not Cleveland Clinic staff, but they admit to those hospitals in the region. And then our family health centers. And if you'll see on the periphery, we extended the geographic area to Las Vegas to the west, Abu Dhabi to the east, Florida, where we have both a hospital and an outpatient facility, and up to Toronto, where we have a family health center as well. So there's no way that you can get a paper chart between these facilities. If I have a patient that goes out to the east side to the Beechwood Family Health Center and has an x-ray, well, I need to be able to look at that, whether I'm on main campus or at our data center in Brecksville, which is not a clinical site, or if I'm here on the Gold Coast. So last night I logged on, cleared all the inbox issues in my EMR, responded to 4 or 5 text messages or staff messages from other staff who needed to know about some patient issues. So how do we create that so that you can do it wherever you're at? And that's just for the docs. And we now have 6.5 million patients in the database, which obviously exceeds the population in our geographic area. We had to transform this so that everybody would be on the same platform and have the same ability to see data no matter where they're at. So a Cleveland Clinic patient can go to any Cleveland Clinic facility. And then how do we extend that? We don't run the trauma center. That's a county facility. Well, when you go to the county hospital, if you're in a road traffic accident, they can get access to your meds, your allergies, past surgical, past medical history, because they're on the same EMR platform. It's very easy for us to share that data in an emergency. So we really looked at this as transforming the practice of medicine from a paper model to a digital model, and then going one step beyond in optimizing care design in terms of the process, the metrics, and creating more value or a higher value. So it takes a village to do this. It's not just something a single doc, an administrator can do, or a nurse. There are a lot of people involved in the care process. So how do we put all this together? It's the family and the patient have to be engaged. My favorite word for the families after total knee replacement, Goya. If you have a knee replacement, it hurts, and it's a lot of work. Obviously, we have somebody in here who has a knee. It takes a lot of effort on part of the patient. I always say I have the easy part, patient has the hard part, and we remind the patient's families that they can help out by simply using a single word, and that's G-O-Y-A, Goya, to remind their loved one that every hour on the hour, they should get off their behind, and they should be moving. More about that in a few minutes. For us in the States, as in Australia, the payers want to know, are we creating value? Who's the surgeon, the specialist, the primary care physicians? How do you tie all that together? Whether it's a surgical episode or an acute medical episode, you need to be able to tie all that together, and obviously the healthcare facility needs to be part of that. Whether you're a group practice like we are, where we just happen to have a hospital, or if you're a specialist or a GP and admitting to a hospital, how do you put all that together? And then I've listed the other folks at the bottom who also need to be part of that, and we'll come to that when we talk about Dr. Connect in a few minutes, because standards organizations, government regulatory bodies need to know about other issues, and they want to be able to review your charts as well. So I think some of you may have seen this over the last few years. We've revised this a bit, but this is our eHealth services platform. As you can see, there's 4 major boxes for patients, 4 major boxes for providers, and we're going to go through a few of these now. The key piece is having what we call My Practice. It's our electronic medical record system. It is ubiquitous, and it is everywhere in the Cleveland Clinic. There are no paper records. And jokingly, we tell the story many years ago when our former CEO was asked, basically, do I have to use the EMR? And he reminded us that, it's still a democracy. We would really like you to use it. You don't have to. But if you don't want to use it, the airport, 15 miles that way. And you had a choice. But using the EMR can actually benefit not only the patient, but the surgeon, the GP as well. And we'll go through a few of these pieces, but let's start with My Practice. How do we hook everybody together? You all know that there's the central box, whether it's up in the clouds or down on the ground, doesn't matter. Hooking up the patients, physicians, nurses, the schedulers, the front desk, whoever is taking care of the patient. And these are some numbers we have from 2010. It's the last group we've assembled, just to give you an idea of the magnitude of what we're putting through the system on an annual basis, and as well on a daily basis. So the number of transactions that are going through, whether it's an inside lab or an outside lab, collecting it, putting it in the right spot in the EMR, it gets to be quite staggering. And we look at the functionality. You have the basic things in terms of how do you take care of the patient. We thought it was most important to get it across the entire enterprise first, and then driving further adoption and coherence on standards. In other words, string text may be fine initially, say 10 years ago, but now how do we parse that data and have specific elements? So as an orthopedic surgeon, what do I have in my knee exam, and how do I standardize that across all of the orthopedic surgeons who take care of patients with knees? Same thing on the inpatient side. There are no paper records. Everything is electronic. Even ophthalmology, we've managed to start to convert over on the EMR. So as we do this, I just wanted to give you some screenshots, whether I'm on campus, any facility, or I'm even on my laptop here in Australia. I can pull up results. I can pull up documentation. If I happen to email or message or talk to a patient, I can drop that into an encounter and simply have it all documented real time. Plus, if the residents, the trainees, are getting a call in the evening and they document it, they simply can copy us, and in some cases, if it's an inpatient visit, they'd send it to us for co-signing it and letting them know the staff's involved. Everything is computerized physician order entry. If I write a script for a narcotic or for a drug, we try and send those e-prescribing. We're still limited by the state pharmacy boards in terms of how the narcotics can go. That has to be a hard copy, but every other medication can go electronically to the patient's pharmacy, and that data is collected when you actually make the appointment. So health maintenance alerts as well. So now I've been able to start to put all this together, and how do I connect this? So we also wanted to provide the same capability for the physicians in private practice who admit to a Cleveland Clinic hospital, because then we, as the hospital, have their outpatient records when that patient's admitted. Whichever hospital in the Cleveland Clinic system they're admitted, or if they're seeing a specialist on main campus or any of our other facilities, I now have those outpatient records. And that physician then has all the inpatient records in their outpatient setting. So we've closed that loop with the physicians that admit to our own facilities. And that has become very important. And on the drug interaction alert, this is where it's of huge value, because if they're put on a new medication, is there an alert between what they have and maybe in the system that they didn't mention? We can have that information instantaneously and at our hands. So here is an example of how we share with those who are not Cleveland Clinic staff but admit to a Cleveland Clinic hospital. Now, what about the referring physician? How many of you have sent notes, if you're physicians or office staff or nurses, sent notes to a referring physician only to have that referring physician say, I never got the fax or the mail? It happens all too frequently. And we said, here's an opportunity to move this to the web in a secure fashion and provide our referring physicians with the same view of the EMR that I get. So when I see a patient and I'm doing a consult, they need a knee replacement, I know who the GP that's referred the patient up is. I can then simply close my note at 5:30 the next morning. Off the note goes to them. They get an email saying, please log on securely. They can log onto the system and see the note just as I've created it. And they get full access to it. Now, we've been able to expand this as well to other areas. The regulatory bodies that need to do the cancer epidemiology data work have abstractors. They used to send a fleet of abstractors to campus to look at data. And we said, wait, why can't we load all those charts in Dr. Connect, sign them up, obviously have the right, we call them security agreements in place, which are online as well, and then give them access to those charts so they could do the review on those specific charts that they should be viewing. So they no longer come to campus. It's a huge cost savings. We physically don't have to provide them with a desk or a computer. They get their training, they can go online, and they use it. And the very first group we did it with, they said, gee, that was really very easy. It was actually easier than having the paper because they could find and search for things much faster, and the review took about half as much time as it used to on paper. Of course, trying to find a chart, if it's paper, you sometimes have some challenges there, but if it's electronic, it's always available. So we've been able to use Dr. Connect for these auditors and also for some of the standards and quality organizations that we can then give access to these records. So when we look at the Dr. Connect system and look at Northern Ohio and beyond, we have over 6,500 users. Those users are actually worldwide because people and docs may refer in from Europe, from Asia, even Australia. We have one user in Australia, happy to say. And this way they can see the note. We do not send them out in paper. We don't fax them. It's all electronic. And also what we've done now for an urgent care facility in Northern Ohio, CVS Minute Clinic, the nurses in the urgent care center, it's not a Cleveland Clinic facility, they're outside organization, but they can go in and see the meds, allergies, past medical, past surgical history for those patients who are in front of them with an urgent care need, maybe an immunization, or they have a sore throat and it's 11 o'clock at night, but they're in the Minute Clinic, as it's called, CVS Minute Clinic, and they have access to the record through Dr. Connect. So we make it very simple. They can sign up electronically, there's no charge for it, and frankly for us, we've gotten rid of the paper and reworking it. So when they go on, they simply go to the logon screen, they log on directly. We also can validate who they are. We have different security systems behind this because all of us have a unique signature when you log on in terms of the way you log on, and that can be monitored. And then this is the view they get. It is identical to what I get when I log on. Now they can only see that patient or the patients in their queue. They can't search the database. And they can see what's new, and they have access to that patient's record 185 days from the time that the patient was last seen at the Cleveland Clinic, which we have found to be more than sufficient time. So again, we're now connecting folks who need access to the record, who can help with the care, because when they're told they need a total knee replacement, as Mukesh mentioned, do you fight it or do you run like heck if I tell you you need a knee replacement? Or do you go to your GP and say, what can I do to optimize my health care so that when I go in the knee replacement, I don't have any cardiac issues or any other medical issues? So now let's switch gears. What are we doing on the patient side? We give them full unfettered access to their record. And that's through eCleveland Clinic MyChart. So we have 384,000 users as of 2 weeks ago. It facilitates all the communication. Patients can see their record, their test results. They can see explanatory information about their diagnoses or their lab tests or a procedure they may be having. The health reminders are there. Their schedule for upcoming appointments. They can request an appointment. They can also do all their prescription renewals online. And then we simply can work it. If it's a non-narcotic, we simply send it out via e-prescribing and they get notified that the prescription would be ready for pickup. So there's a lot of information that they can go online. Just to give you some examples here, their inbox, messaging their physician. And by the way, for anybody who's played telephone tag, having it electronically really does put a lot more control in your side, because then the patient has it in writing. They may not write it down when you're talking to them, but now if they have your answer in writing, they can read it and read it and read it again, and their comprehension level goes up. They can look up their test results, and you can see their links. They can get the results. They can look at each of the individual items and what is a potassium, what's a glucose, what's a creatinine, and then what do they have on the preventative care side in terms of tests that are upcoming. It is a bit disconcerting to see, though, that you have 9 years before your next colonoscopy. It's always there as a reminder. We're thinking of maybe making it a little bit more closer to the time you actually need it, and requesting a certain procedure if it's time for a bone density or some other study. All of that is online, and the questionnaire to help sort it out in terms of which of the different categories you might fit into. It's all there so that we can handle the request electronically. And then going beyond the medications to explanations, what you're on, details about that, drug-drug interactions, prescription renewal. Everything is right there for the patient to use. So again, we're connecting them to the system and cutting out the friction. If you recall, how many of you actually visited a bank teller sometime in your lifetime? You know, this will date some of us. We asked a group of 15-year-olds what the lady was standing behind a counter. And the 15-year-olds had no clue what a bank teller was because they'd never been in a bank. All they thought was mom or dad went to the wall and simply put something in, put a number in, and got money back. One smart kid said, no, my dad goes to the printer and gets the money for me. We got a little worried. So here they can then select their retail pharmacy, either pick it up or, again, e-prescribing. So what about patients that have had procedures or patients that have something that needs to be monitored? How do we do this? How do we get that information off of the glucometer or off the INR reader for anticoagulation if you're on Coumadin, and get that data into the inbox so that it can be handled by the clinical team and advice be offered? Well, you can do it for EKG and pacers. There's a lot of data that comes off of these devices, and we can feed it right into the inbox of the clinical team. So it may not just be a physician, it may not be a nurse, it may be a clinical team. In my case, my clinical team is myself, a physician's assistant, and our secretary. So each team is a little bit different. For knee replacement, we found that our patients were going home and not always being compliant. You know, imagine that. So now this is an early device that we're modeling here, where you've got the transmitting box that has all the data come up to it. Here's the knee sleeve, standard postoperative knee sleeve with a little goniometer embedded in it. We've since gone to an accelerometer system, but now we can tell what you're doing during the day. We know what time you got up. And if you tell me that you did certain exercises, well, we know what those tracings mean. We've dissected this out, and we know that there's 5 families of activities. And if you said you did your heel slides, there's data to show that you did your heel slides, but you only did them for 2 minutes. You're supposed to do them for 10. And if you have a flat line, no activity, like you're asystolic, your knee's not moving, we can call you up and ask if you're still alive. Well, this is, as one of my patients said, this is Big Brother watching, and I said, no, it's your knee surgeon watching who wants you to have a good outcome. Because the sooner you move, the sooner you get better the range of motion you have, the better your activity level will be. So as he said, the feedback mechanism will either be 9 volts or 440. He needed 440. But now we can tell what the data is. That data can get transmitted either through Wi-Fi or a cell device or a direct hookup right into the EMR, and it can be acted upon in a timely fashion. Now, if you have a good home health care physical therapist who's working with you, they provide the same data, but again, there's a delay. I want that data to go right into the EMR to the clinical team, which would include that home care physical therapist, and then we can all act upon it and make sure that they're within a certain range. When should you achieve certain ranges of motion? When should you be past 90 degrees? So these are things to come to hook up that patient post-op and connect them so that they're engaged and not just coming back 3 or 6 weeks later. Well, another opportunity we had was we would get asked a lot about a second opinion. And My Consult is our online second opinion program. It's very simple to use. There's 7 steps. This gives you the schematic of what it is, but who's the requester? Who's the patient? What's your diagnosis? We can't do it for all 6,000 diagnoses in healthcare, but we can do right now about 1,200 for which there's enough objective information that you can send it to us. You can upload it electronically, and the image upload actually is going live shortly as well. Otherwise, it's sending us the disk. And then payment, we have a number of folks that are under, as a corporate benefit program, we have 6.5 million lives that this is provided as a corporate health benefit, and then otherwise the other half are consumers. And then there's intake questionnaires, a general medical questionnaire and a diagnosis-specific questionnaire. Same questions you get asked if you were in front of us. And then what do you need to send to us? Nowhere in the health literature was a listing of saying for atrial fibrillation or knee arthritis, here's the minimum data set you need to have to make that diagnosis. So we asked our specialists to go through and make that list for us, and that became, we call it the materials checklist. And then once all that's into us, it's reviewed by our staff physicians, and they provide a written report to those patients. So we have a number of companies like General Electric that now provide this worldwide for their employee population. You know, we outline the 7 steps, as you can see here, as I just went through. And then the questionnaires are very straightforward. We actually say, what are the 3 most important questions you'd like to ask your physician? And of course, the maximum number we've ever had listed is about 44. That actually makes it easier. That patient is very engaged asking specific questions. And if we simply answer their questions, they're going to get the information they seek, and they can make a better decision about what to do next. And I just want to quickly share with you that it's rather shocking to us that we agree with the diagnosis in 75% of the cases, and in 10% of the cases, we feel that the diagnosis has been made as flat out wrong. And on the treatment side, you'll see that there's no changes here in 36%, minor changes in 22%, moderate in 25%, but that means that in 17%, the treatment that's been recommended is wrong. And that's very shocking to us that it was so high. And what's interesting in prostate cancer, it's one area where we've seen the pathology has been read incorrectly in upwards of 30% of the cases. Now, we think that's in part because some pathologists don't read genitourinary pathology all the time. We have 7 pathologists who do nothing but read genitourinary pathology. And some of these subtle differences between a Gleason 5, 6, or 7 staging are quite significant in terms of what you do going into the future. So we've currently done consults from all over the world, and this continues to expand, but that's connecting folks to what we're doing on main campus, and it is these connections that matter. For us, we really feel that having that model healthcare delivery system transitions from what we call a provider-driven program to a consumer-driven healthcare delivery system. And that's a key point. Quality and efficiency, you can't know your outcomes, you can't know your data unless you collect it. And if you're going to collect it, you have to put it in a repository. You have to look at each and every event. And then the health IT should be supportive. It's got to be the engine that runs this. And that's what all of us in this room need to do, is to empower the patients with technology to make the enhanced and convenient access to health care actually occur. We have to get rid of the geographic barriers to care and get the right patient, the right care, the right time, and the right value, and we have to do it anytime and anywhere the patient or the provider or the system is at. So barriers need to go away. You know, we're not going to break the bank, but it does take money to support this. But the amount of value that we can create is significant and certainly overcome what that initial investment is. And Mukesh has a favorite quote that I've loved, and that's, fortune favors the bold, but abandons the timid. The only thing I can't figure out from this picture is who's timid and who's bold here. But you know, it really tells us that we've got to take a chance. We've got to try and swim against the current, go upstream, and make things happen for future generations. So this is not coming July 1st, as we've experienced in the States. This is not the end of a race. We are barely getting up to the starting blocks. This is a marathon that will transcend any of us. We'll be long gone, our grandchildren will be here, and they need to make sure that they take it to the next level. So we need to start the marathon in search of better health care. We need to move forward and make it happen, because if you make the effort to move forward, you will see more and more accomplishments. And that's what we've seen as we've devised our eHealth services at the Cleveland Clinic. Thank you very much.
Ladies and gentlemen, I know I can thank Johnathan on behalf of all of you for a marvellous vision of a dream Rolls-Royce future. Can I just quickly ask you, what proportion of the population in the United States would have access to something like that?
Actually, it's increasing every day, and with our meaningful use regulations, we're seeing more and more adoption. So this is regulations coming out from the government. It's an incentive program, at least for the first 4 or 5 years. The disincentives, penalties, start in 2015. So we are seeing right now that, depending on where you're at, you know, I would say 50% of the population has a comprehensive system. Is it perfect? By no means. But what we're trying to do is see folks get engaged. And there are people who just don't use the healthcare system. They're healthy, they don't have a GP. You know, when was the last time you were at the doctor's? Never, or years. So it's really that episodic care that we need to cover. And so it will continue to increase. We have a number of hospitals that have reached what we call stage 7. And if you know Dave Garrett's work on the adoption chart, that is increasing. It's very gratifying to see that the rate of increase is increasing.
Ladies and gentlemen, the Minister for Health, Tanya Plibersek, is with us and has heard Dr. Schaffer's presentation, and I'll bring her up shortly. Dr. Schaffer will be on a panel later today, but is there anyone with a question or a comment? Please take this opportunity in case you... Thank you. Do you want to just stand up and introduce yourself? I'll hold it.
George Margellis from Care Innovations. So John, thanks for a great presentation, and you pointed out one key differentiator at Cleveland is this concept of annually reviewed, contracted, salaried clinicians. Do you see that as the determinant that drives a lot of the success what you have?
Well, some of the docs outside the Cleveland Clinic look at it and they get quite nervous. I have to tell you, it's actually quite cathartic to once a year go through everything and say, oh gee, I didn't do that. Or to get that list of computer-based training programs that you need to recertify in every year. I think there's a lot of benefit to reviewing our performance. You know, businesses have been doing this for years. But in healthcare, it's just not something that's been adopted. So I actually think it's very healthy. As one of our docs said, he's now been on his 45th one-year appointment. You know if you're not doing well. It's not a surprise. But it's an opportunity to put together your package and say, gee, you know, self-reflection, I could be doing things better. It's no different than what we do for our children to push them forward to do well in school. And what are they going to do for their future? But as we get to be adults, who does that for us? We need to do it for ourselves. So I think it's a very healthy way of doing things.
We have another question here.
Well, it depends who you ask. You know, nobody ever feels, and I'm sure there's nobody in this room ever feels we're compensated for all the work we all do. But, you know, it's more than satisfactory. Yes.
Hi, Johnathan, Stephen Chu from NIDA. Thank you for a very interesting and exciting presentation.
You're welcome.
The greatest challenge for clinical informaticians on eHealth is determining what are the proportions of the clinical data to structured and what to structure. So do your organization have a established principle as to how much do you need to structure and what do you structure?
Well, there are two ways of looking at that. If you look back to medieval times, there were a lot of devices that would help to tighten things down, like the rack. So we wanted to start initially of getting everybody on the EMR. If you dictated your note, fine. It's in the electronic record. It's there. It's string. It's not parsed or divided into buckets for everybody else's benefit. But getting it in the EMR. Once we get everybody up on the same platform, the same system, then we can start to get the engagement of the clinicians to say, okay, if I want to collect knee range of motion, I have to have certain elements. What's extension? What's flexion? What are the normals? And how is it recorded? So starting with breadth and then going depth and getting engagement. So I would say, don't try and parse it initially. Try and get them to at least record the data. And they may not record everything you want, but get whatever they have into the electronic system and then get engagement, groups of clinicians. The champions will self-identify. And in the panel, we might have time this afternoon to discuss some of the specifics, but I've saved time by going electronic. When I see a patient and I book a total knee replacement, I've got all the preoperative consults are there, listed, and ordered. The equipment I use in the operating room is there, listed, ordered. The postoperative care, do they live on a ranch, one floor? Do they have two floors? Do they have a spouse? Do they need to go to rehab? Can they go home? Which home care agency? It's all in that initial visit. So no longer does that happen piecemeal. It's all there at the initial visit, whether I put it in or my physician's assistant puts it in. It's in our note, it's in the order set. So frankly, from my perspective, it's made me far more efficient.
Ladies and gentlemen, there will be another opportunity for questions with Johnathan later today, but would you please thank Dr. Johnathan Schaffer?
Thank you very much.